Yes. Very silently. Yeah. Okay. Just waiting for. Yes. Yes. Yeah. Pretty good, actually. Oh. Good. The girl sings. Well, it's for lack of this like you're like fine. I think she wants to fight it. It'll be good. Yeah. Did you guys do the screen share? Yeah. I could say after that laugh. Yeah. Hi everyone. Like they said at the beginning, my name is Andrea and this is Baylee, and we're both students of genetic counseling at the University of Cincinnati and Cincinnati Children's. So just as an overview of what we're going to be talking about today, we're just going to do kind of an introduction about us so you can know who's talking to you, go through genetic counseling, what it is, a little bit of information about the program as well, some case examples of the kinds of things that we can see, and then we are going to leave it up for questions at the end. So again, my name is Andrea. I'm a first generation Mexican immigrant. I moved to the US about 6 years ago. I'm going on 7 years. I graduated from NKU in 2021 with a Bachelor of Arts in Psychology and a minor in Spanish. So a lot of the classes that you guys took, I took in the past. I am a second year at the University of Cincinnati Genetic Counseling Graduate Program. And something cool that I get to do is that I'm a qualified bilingual staff level 3. So that means that in my training, if I have a translator, they can't hear. Can people in Zoom hear us? Oh. Yes. Okay, perfect. So I'm just gonna say that again. I'm a first generation Mexican immigrant, going on 7 years in the US. I graduated from NKU in 2021 with a Bachelor of Arts in Psychology, minor in Spanish. I'm a second year graduate student for genetic counseling at UC. And then again, the cool thing that I do get to do in this part of the program is I'm a qualified bilingual staff level 3. So that means that I can have a translator present with me at an appointment to translate from a supervisor but I'm able to provide services in Spanish to my patients if possible.
Andrea, did you win a senior award too?
Yeah, I did, but we're not gonna talk about that, it's fine.
Okay, and a little bit about me. So I'm from North Carolina. So I graduated from the University of North Carolina at Chapel Hill. If you're familiar with the Tar Heels, big basketball fan. And so there I double majored in biology and Spanish. It's okay. And I'm currently in my second year, like Andrea, in the genetic counseling program here at Cincinnati. And a thing about me is that I'm also a LEN trainee. So that means I'm in the LEN program at the University of Cincinnati. And what that is it's leadership, education, and neurodevelopmental and related disabilities. So I will just refer to it as LEN because it's a mouthful. But basically what that means is I get specialized training in neurodevelopmental conditions like autism or kids with developmental delays. And I work with all other disciplines. So my cohort isn't just genetic counselors, but it's also audiologists, pediatricians, speech language pathologists. So I get to see the care of patients with these conditions through different lenses and disciplines, which I think is really neat. And all people in our cohort have the chance to be involved in it, like Andrea is involved in it, just she doesn't have to go to all the lectures, whereas I do. So I think that's a really cool part of our program.
Now moving into talking about what genetic counseling is and a little bit of information about the program.
So we just wanted to start off with talking about what genetic counselors do. So the first thing that we do is we provide information about genetics, inheritance, and specific genetic conditions. So that looks like being the expert in the room on genetics. So a lot of providers don't actually get genetics information. You'd be surprised how little genetics information that doctors and physicians actually get in medical school. So we are the first line kind of defense on the genetics front in the room regarding genetics. And that looks like also discussing the benefit, risks, and limitations of genetic testing, which is always rapidly changing. And we mostly counsel on clinical genetic testing. So if you've heard of like 23andMe or Ancestry and stuff like that, that's more direct to consumer, but can still imply some health risks that we might see in clinic as well. But we mostly focus on the clinical side of things. And then we also help to interpret those results because we're especially qualified to be able to interpret that information as compared to providers that don't have our training. And most importantly, along with that is we help patients make decisions about that genetic testing. So it's a lot of seeing where the patient is coming from in their journey to genetic testing, helping them decide if it's the right thing for them and what they would do with that information. And along those lines, we help to provide support to patients and their families as they're going through this process, because genetics can bring up a lot of family dynamics. It could bring up a lot of uncertainty that we are uniquely qualified to counsel on because it's a part of our training. So how to become a genetic counselor. So you need to finish an undergraduate degree, a bachelor's, and that doesn't really have to be in a particular major. So my background was in biology, but Andrea's was in psychology. So we came into this program with different perspectives and different training and information on what genetic counseling is, but you don't have to have a particular major. You just need to make sure that you meet the requirements. So a lot of times that looks like for programs completing a psychology course, doing social sciences like maybe sociology, and it also requires more of that biology focus, so more of the actual genetics, statistics, things like that. And then you apply and you interview for places and you get matched. So now you're in your master's in genetic counseling. And what we're doing on a day-to-day is we're balancing coursework. So that's pretty equally divided between the more sciencey genetic stuff, but also with psychosocial classes, which you guys might be more familiar with in psychology. And I wasn't as familiar coming in because I didn't have that psychology background. So it's the thing that drew me to genetic counseling was it equally balanced that science and that psychology piece, that person-centered care. So our coursework reflects that as well. And then we have our clinical training. So 5 weeks in for our program, we're starting in clinic with observing and working our way up to different roles and patient appointments. And at Cincinnati Children's, there are a ton of specialty clinics that you can work in that all have their own unique indications as well as psychosocial things that you need to counsel on, because genetics is a really big term, and there's a lot of specifications that go into that. And then also a part of our training is research, so contributing to the field that we're becoming a part of. And so we each have thesis projects that we can talk about in the end if you have any questions, but our program does a really great job of, even if you don't have research experience beforehand, really providing you with classes and coursework and things to be successful in that research. Is there anything that you wanted to add about our program and what we do?
The 5 weeks, it is something that is unique to our program. Not all genetic counseling programs, you don't get to start rotations and seeing patients right away. A lot of them start during the summer of your first year. With us, we start since 5 weeks after we've started the program, which is something that is unique. Can sound overwhelming, but it does give us more time to just work on all the skills that we need to achieve in that program.
Yeah, I think that's really important to highlight because all the programs are going to be a little bit different. There's not like one central location where you apply to programs. Each university or institution has their own like portal. So they have their own requirements, and along with that, they have their own like way that they set up the program. So this is just our experience at Cincinnati, where we are fortunate enough to start our clinical rotation so early. And then after you graduate with all of that training, you can start working as a genetic counselor right away. So we are actively applying to jobs now, which is scary, but it is just a part of the process. And you can start before you take your board exam. So you just have to take the board exam within around a year of graduating. And that just means you're a certified genetic counselor once you pass it at that point. And then some states, Ohio requires this as licensure. It just means that you're credentialed not necessarily by the institution that you work in, but just it's in the law of Ohio. So why to become a genetic counselor? So obviously we think it's great. We're a little biased, but to give you guys some more concrete things, we really like that along this job is lifelong learning. So genetics is constantly changing. So you really do need to stay on top of that. But also in terms of lifelong learning, like every patient you see is going to be different. They're going to have a different background coming into the appointment. They're going to have different emotions, even about the same indication that you've seen. So you're constantly learning and shaping to better treat and care for your patients. We actually have one of the highest job satisfaction ratings. You can see that it's a 90% job satisfaction rate. This was the most recent report from a survey that went out to all genetic counselors that are currently working. So people get a lot of fulfillment from this type of job. There's also a lot of job security. So our field is actually one of the highest percentages job growth within the next couple of years. And that's because you just frankly don't have enough genetics providers to handle the amount of genetic testing that we're currently doing right now. So we definitely need people to join the field. So really everywhere you look, there's going to be a genetic counseling position, which is great for us in grad school. And that's why we're interviewing now, because there's such a need. If you have a passion for science, but also a passion for psychology, for helping people and wanting to help people cope with this uncertainty in the conditions that we can talk about in genetics. If you have a desire to work in healthcare and be a part of a system to provide clinical care to patients, this is great. I will say that we don't touch patients, though. That's not in our training. So we don't deal with, some genetic tests require blood draws. We don't do those. Some require saliva swabs or like cheek swabs, and we don't do those either. Our training is strictly talking to patients. And if you enjoy empowering people, so I think the big part of our profession is that we're not only just talking at people about this information, but we're trying to help them learn how to use it and how it fits into their care moving forward. So I think that's really unique about our field. So who are genetic counselors right now? So again, on that survey that went out, genetic counselors are 93% female and about 90% white European. And this is definitely an area of growth that we need to have in this field, because we know not all of our patients are white females. There's a lot of data that backs up that if you look like the patient population you're treating, you're just providing better care. And so NSGC, that National Society of Genetic Counseling, has a lot of initiatives to be able to bring that representation of genetic counselors counselors into what we're seeing in that patient population. So it's sorely needed in genetic counseling, and there's a lot of initiatives to help bring that in. And so I linked here, there's NSGC has a specific task force dedicated to this where they have all their initiatives listed. But there's also a lot of genetics networks that are dedicated to diversity and equity. And one of them is Golden. You can find them at Golden DNA2, and that particularly is for Black prospective students that are interested in genetic counseling, and they're on Twitter and Instagram. And then the Minority Genetic Professionals Network is something that Andrea has a little bit of experience with, so I'll let her talk.
Yeah, so with that one, it is open to anyone that is, of course, of minority background, but also people that just want to be allies, that want to be involved in seeing how they can help their peers who are part of any minority groups, can go from any ranges. It is something that can be extremely helpful. They will sometimes go in there and post jobs, or if anyone has questions. I know in the past, I have dealt with situations where I just didn't know what to do, either with dealing with a supervisor or like how to provide the best care to a patient that I hadn't, something cultural that I just really wanted to make sure that I was being just sensitive to it. And they're just a great resource with any kinds of questions that you can have. And also prospective students can join that as well. It's not just for people who are already in the genetics area. So here we just wanted to put a little bit of information about the match data. It is a little bit cropped at the top, but I hope you can see it. Basically, it's just showing how it is still mostly white people in the program, but they are us doing this. We're trying to reach out to more people who could be of different backgrounds, not just your typical white females that could be interested into these kinds of programs so they can join. Because how would you know that you can apply to something like this and no one has told you before, which I know it was my place when I first came into NKU and to my degree, and just later I found out about genetic counseling. And then here, I just wanted to highlight the kinds of backgrounds that you can have, so you can see that just biology, well, the red represents the people that are matched, and the blue the people that are unmatched. It is a really competitive program just because there's not a lot of people that can offer this kind of training, and then how many supervisors can you have during the program as well. That's why it can look intimidating, but people can keep applying in different cycles. Not because you're matched once, that means that you can't go again. You can keep trying until you want to hopefully get accepted. So again, there's a huge chunk for people who have the biology background, but if you would have the psychology, there are going to be people from social work, from zoology, really multiple different backgrounds. I think that's something that's really interesting and unique about this genetic counseling degree. They are really looking again for that diversity, not just with the obvious things like sex, gender, ethnicity, but also what's your background, like something unique that you can bring into these types of programs.
And I think that's something that's unique about our program as well. So we're one of 11 in our program. And some people have biology backgrounds like me, and some people have psych like Andrea, but some people also like aren't recent undergrads. We have a student in our cohort who actually went to med school, and then after she finished her 4th year said, I don't want to do this. Like, I want to be a genetic counselor because I didn't like what I saw the geneticists do. I liked the counseling aspect of genetic counseling. And then we also have a student in our program who was a professor for most of his life in genetics, but not necessarily human genetics. And he found out about genetics when he was later in life and applied and matched to our program. So you see a lot of different backgrounds come in with these cohorts, especially because of this match system. So you kind of just get matched to a program and there you are and you attend. And I think that's really cool that we get so many different perspectives through our 2 years of training with these great peers that we have.
And then just to have a little bit about the psychology in genetic counseling. So the psychological support that we provide is mostly through psychosocial counseling. So we are really just trying to help the patient in that moment with any anxiety that they may have regarding to the healthcare, or just any of those feelings that they can come up during the discussions that we can have. It's not always guaranteed, but sometimes in the most surprising moments is when it can come up. So some common emotions, feelings that can be seen during these appointments can be guilt. People can feel guilty because they have or they don't have a genetic condition. They can have some grief, just they're grieving the loss of someone that they love, the loss of normalcy, the loss of the life expectancy that they thought they were going to have in some cases. They can have anxiety because in genetics, things aren't always straightforward. So we're limited to the information that we have in front of us. So if it's something new that we haven't seen before, they don't know what they can do. So we are trying to deal with that anxiety that can come up and just try to offer our support. Other thing can be blamed. They can blame themselves for having something and don't know, and then having a child, and now this child also has that condition. So then we're just trying to do with all the things that that appointment can encompass. We also deal with referrals. So not all of the appointments we're going to be able to provide the kind of support the patient needs. And we also need to be aware of that limitation. So we can refer to social work. We can refer to a psychologist, to a psychiatrist, to the people that they're going to need to make sure that they are well taken care of. Again, we can also help with decision making. I think that's something that comes in psychology because we need to learn how to not be biased. So we need to provide all of the information that the patient can need. Sometimes they want to get testing, sometimes they don't want to get testing, and just showing that each path that they choose is going to be fine. In some cases, they don't want to be there talking to you and just letting them know, you don't have to sit here with me, that's fine. And not taking personal learning, just how to deal with that direct versus indirect decision making.
And our psychosocial training in our program definitely was maybe like a week or two of didactic training. So lectures led from a psychologist who was helping us learn how these different approaches and these definitions for different psychology approaches. But then the last half of that course was really active. It was role plays every week that we did with each other, where we are vulnerable. We are counseling in front of our peers in a small group, and you really learn from your peers. And like Andrea and I were in the same group a lot of times, and it's just really cool to see your classmates actually counsel, because we don't get that experience because we're all in different rotations, but you really get feedback from your peers in that moment. And it was great to get feedback from Andrea, who had this psych background, to help me like navigate different ways that I could have had a conversation better, because I didn't have the background that she did. And so it's just really neat that you get to learn not only from a psychologist, but also from your peers who have this really valuable background experience.
I guess with none of that, I took counseling psychology during my time at NKU. And I can not happily say that I was not appreciative of the role plays that we had during that class. It was also during COVID, so it was virtual, so it was a little bit awkward. But then I was able to take that knowledge and apply it here and just be able to explore it further than if I had not taken that class in the past, for example. And then I also found this article from Psychology Today. So if you guys want to, you can scan and read a little bit. It's going to have some of that information that we have discussed so far and a little bit more. It is a little bit outdated because it's from 2016, but it's basically the same information. And then here are just some resources where you can learn more or connect with a genetic counselor if you want to. Of course, as an NKU undergrad, feel free to reach out to me. I'm happy to give my email and just give it to people, make sure that it's updated as I keep along in my training. Again, I know during my time at NKU, I didn't know about this. So if more people from NKU would like to know about this program, would like to hopefully in the future meet with a genetic counselor, I'm more than happy to be a resource. But again, there's those links to the NSGC. And then if you want to do an informational interview, again, just to learn a little more about the field, you can go to those websites.
And then here are some other resources. So I feel like the main place to learn about genetic counseling is that NSGC website that Andrea was just talking about. But there's also a lot of information about genetic counseling on different platforms. So there's a lot of podcasts that I personally listen to because I learned about genetic counseling during my undergraduate career, but then I didn't get to shadow or anything because of COVID hit during my junior year. So I didn't get to go in person and learn about genetic counseling. So I relied a lot on these other platforms, which I think are great. So here's some podcasts that are listed that are on Spotify and Apple Music. And then also I recommend following Dina DNA on Instagram, TikTok, and Twitter. She does a really great job about talking about genetic counseling for the general public. And we just think of her as like a celebrity in the genetic counseling world. And then also one of our students, our first years, actually has a YouTube channel where he made videos doing interviews with different genetic counselors that are really informative, and where he talked about his experience going through the interview process, as well as his experience now in his first year. And so I'd recommend looking at that if you want to know more specifically about like our program, for example.
So now moving on to case examples, we each have one depending on the time, and if you guys have any questions, we may stop after mine or we may continue with Baylee's. This case that I'm going to talk about was one that really surprised me, just because I basically didn't talk about genetics the entire time and I just offered psychosocial support. So this is a prenatal case. It was given in the Fetal Care Center, Cincinnati Children's. So this is one of the clinics that you can go to in your second year if you choose to go to. It is more intense in the way that you are rarely going to be given any kind of good news. A lot of the people that come to these appointments, they have just some really serious conditions going on for the baby or fetus of that pregnancy. So in this case, I saw this female patient who was 46 years old. She was almost 25 weeks gestation at that point, so in her second trimester. She had a history of having 2 healthy boys, and she had had 2 miscarriages before. So this was her 5th pregnancy, and she was referred because there were multiple congenital anomalies going on. So really serious things that the providers are being able to see during an ultrasound appointment that they were really concerned about. And it was suggested of a trisomy. So a trisomy is when instead of having your pair of chromosomes, you have 3 instead. And then the patient did do diagnostic testing before coming to fetal care, which confirmed a trisomy going on. So a lot of the trisomies that we can see, they can be life-limiting. So in my head, when I first had this patient, I was like, well, if the patient already received a genetic diagnosis, why are we meeting with her? In my head, before going into this clinic, I was just really, really confused. They got testing, they know the answer, what can I do now? And that was still one of my favorite conversations, because I was just talking to my supervisor, like, Andrea, we can do so much more for this patient. So the condition that was going on in this case was trisomy 18. So trisomy 18, I guess, is one of those serious life-limiting conditions. A lot of the time, it results in a miscarriage. If the patient is able to deliver the child, it can be a stillbirth, or sometimes they can live from a couple minutes to a couple days. In some of the, not a lot of the cases, but sometimes they can live up to a year. So the findings on this patient's ultrasound was a strawberry-shaped skull. So that's just something unique of this trisomy. Anytime you see something that says that a strawberry-shaped skull, we think of trisomy 18. There were some brain abnormalities going on, so the brain was not developing in the way that it should have been. There was an omphalocele, so in that case, it's basically all of your organs inside of your digestive organs are outside of your body, and it's covered by a membrane. They also had a congenital heart defect, so I don't remember exactly what it was, but it was just some serious heart defect going on. Suspected hypertelorism, so just the eyes were really far apart, more than it should be. There were normal hands and feet, so there was club feet when the feet are just kind of like pointing inwards, and the hands were just clenched. They were not straight. And also micronausea, which that's just your small jaw. So the appointment was over an hour long. I reviewed the imaging findings at the beginning of the appointment. So when you go to fetal care, just because they have more of an advanced imaging software, they're going to be able to look at things with more detail. So we always make sure to review everything that has come up in case there's something that somebody else thought it was there, but it's not there, or just something different has showed up now that we have met with them. It was a lot of exploring her feelings. The patient was going through a lot of grief. There was a lot of denial. She was still trying to process this, even though this was a diagnosis that has been given around a month before meeting with us. She was still having a really hard time just accepting the fact that She didn't think she could get pregnant at 46 years old. Now she's adjusted to getting pregnant. Now she finds out she has a kid that may not be able to, she not may be able to give birth. So it was a lot of just dealing with all of those feelings that were coming up. So it was a lot of psychosocial support. It just went from the patient not believing that this was happening to her, just not being able to keep it together anymore and just crying and not understanding what this was going on. She also, with some exploring and probing, I was able to learn that she had seen a kid that was in intensive care when she was working with a family, so she did not like the idea of her two boys see that for the kid. She didn't like the idea of just her other sons seeing their baby brother with just tubes everywhere and just not being able to read on his own, for example. And then she had a mom in the appointment, so it was also dealing with the emotions of the mom of the patient. She wanted to do different treatments that the patient wanted. So it was a lot of going back and forth between the two of them and just providing support for not just the patient at that moment, but also the mom that was involved in her care. And at the end, it was just providing the resources that this patient needed. We discussed about all of the treatments that could be done, all of the options that she had for this pregnancy, and in case she wanted to do memory making. So that's something that we also talk in our second year about the kinds of things that can be done for stillbirths for people that are going to pregnancies through Cincinnati Children's that's called Starshine. And something unique to this case is that I brought up that there are photographers that are specialized in stillbirths and just kids that have differences in how they look. So the outcome of this appointment, we feel okay, you're supposed to have a team meeting afterwards. She did not come to the team meeting. There was too much going on. She had to leave. I thought we were not going to see her again. And she had made a choice for her to not continue the pregnancy, but then surprisingly, she came back next week, adjusting. Unfortunately, a couple weeks later, she did end up having a stillbirth, which does bring a lot of feelings as a provider when I was so involved in that care, but it's also, in a way, a lot of these patients don't want to make a choice. So then that way, it just went the way that it had to go, and she didn't have to make a choice in how things were going to go. What was interesting about it is that when I was talking with her during the appointment, what she was so surprised of was the photographer that she could request that is free of charge and could take those pictures for her to be able to have with her. And that was the first thing that she requested after she had that stillbirth, which for me, she's not going to remember my name. She met with me during one of the worst times of her life, but I was able to make that impact and make sure that she was able to have those pictures that she wanted. This is not a patient, this is just for, the organization is now laying me down to sleep. You can see some stories from patients and some pictures that I have examples of. So this patient was able to request this to make sure that the baby was remembered and that the family could honor him in a way that was special and meaningful to them. So that's how psychology can be involved. Not all the cases are going to be like this. They're not always going to be this heavy. But when you have that training, you have that background, and we have those role plays when we're training how to give difficult news, how to deal with emotions, how to deal with grief, we're able to provide the best care for the patient in all the ways that they can have. Because again, in this case, she didn't need to talk about genetics. She didn't need to know what was trisomy 18. She didn't need to tell her if her baby was going to have X or Y kind of surgery, or she didn't need any of that. What she needed was someone to listen to her and to provide the resources that she needs and wanted. So I know that was a little bit heavy, but we just wanted to stop for a little bit and see if you guys have any questions. If not, Baylee can also take over and show one of her cases from a different kind of clinic that she's been involved in.
Any,
What'd you say is the most difficult part?
I think it depends. So something difficult that can happen can be burnout. So with these kind of things, you can get burned out really quick. So you need to understand what you're able to deal with, what you're able to not deal with it. So for example, from my training, I know I can't do peds. Pediatric cases are just really difficult for me to deal with because I get too attached to them, which is interesting because I just talk about this really difficult case, but I'm able to just put my walls up and be, I did this, then I can go home and I'm not taking it home with me. But with these cases, because I have more of a personal connection to them, I'm not able to do that. So for me, that can be hard in my training. I don't have a choice where I'm going. So I know during my last pediatric rotation, I had a really emotional hard time being able to just separate the two apart.
Yeah, that happened to me during my first rotation at Cincinnati Children's. And that was really hard for me because I saw myself in a lot of the patients that we were seeing because we have similar diagnoses. And that was like very difficult for me. And I realized like, I just can't work in that specialty. And sometimes in your training, like Andrea said, you do have to work in these places because it is important to know about different specialties, different conditions. But I think that's where it's important. Like after we graduate, we have the freedom to choose what specialty we work in. And there's not like a residency or a fellowship, like we can switch around. So I think that's something that also helps people with burnout is that like if they're feeling really burned out in a pediatrics clinic, sometimes a change of pace is really helpful. So you don't have to go back to school to work in cancer. You can just work in cancer. And so I think that's what is really helpful, like as a student realizing like, okay, once I graduate, I will have a lot more freedom and what like my day in my clinic is like. A great question. Yeah. Any other burning questions? Okay. I can talk about, let's make sure it's the chat. Okay. So I can talk a little bit about my case. It is not as heavy as Andrea's case. But I was in my summer rotation when I saw this patient, and I was in a cancer setting. So what that setting looks like is a lot of talking about family histories of cancer and empowering patients to realize that they don't just need to accept that cancer is going to happen to them, that we can offer genetic testing to see if they're predisposed to developing cancer in their lifetime. So this is MG. He was a 32-year-old male presenting to clinic with me. And he was actually diagnosed with brain cancer at 1 year old. And at that time, there wasn't a lot of genetic testing that we could do, but that genetic testing changed a lot. So when he was 17 years old, he had negative single gene testing, which was for the gene that was the most suspicious to cause a brain cancer this young in a person. And it was negative, so they didn't get an answer. And so flash forward to 32 years old, he just had like a routine ultrasound and they identified a growth in his abdomen called a neurofibroma. Now this is just a benign growth, but sometimes it can be associated with a particular genetic condition called NF1 or NF2. And so he was just presenting to our clinic to see if he could get testing so we could rule out this diagnosis in him, and also just to revisit genetic testing because it's been a really long time since he had it at 17. He had a really strong family history of cancer, which I will show you in a second. And then another part of my prep was also looking at like the social history for him, which it did have some information on. So he was recently married and they had a lot of preconception appointments and genetic counseling. So they were really interested in family planning. So something that was on my mind going into this appointment was how his personal history of cancer and his family history of cancer would influence their decision to go down natural family planning or whether they were really interested in some sort of alternative family planning like IVF or things like that. So this is a lot, I know. So this is probably bigger than most pedigrees that, I typically see. So when we take a family history, it's really hard just to listen to the words people say and be able to find patterns in that. So we draw it out, which is probably a lot more in depth than other providers do. So here is my patient. We have squares as males, circles as females, but obviously we know that gender isn't that complex, isn't that straightforward. And so there's none on this pedigree, but we represent non-binary individuals by a diamond is what we do. And then there are specific guidelines for how to most appropriately represent transgender individuals too. They're just not represented here in this family. So this was my patient, and listed under him is his age and that personal history that I just explained to you. And then these are all of his siblings right here. And then we work our way up and we see his dad and his mom, and we see some, history of cancer really on both sides. So when I look at this family history and particularly this one cancer that he had, even though it is at 1 year old, isn't a brain tumor that really screams genetics to me. What screams genetics to me is breast cancer at the age of 25 in his cousin, who was also tested for that gene. They went through that genetic testing process together to get tested for that gene. So really breast cancer is more of what's on my mind for going on in this family. So we can go to the next slide. So I can just stand closer because I'm gonna need to hit it. So the start of the appointment, I started out with contracting. So that looks like asking what the patient's understanding is, what their goals were, really just trying to see where the patient is coming from and meeting them where they're at. And it actually was a lot of psychosocial, which is why I think contracting is such an important piece of addressing the psychosocial concerns of patients, because you really just open it up, asking questions about how they're feeling. And they were really angry, which I was not expecting. So they had presented to one of their appointments where they were talking about this possible genetic condition that he had. And the provider told them like, oh yeah, well, we can just like refer you for genetic testing. And then I reassured that we could offer them genetic testing that, for example, the biggest panel we could offer them was 91 genes. And they got really mad because he was like, I was tested for one. Like, why wasn't I tested for all of these? Did I just not get good care? Like, I don't understand. I'm really frustrated. Why I only had testing for one gene when you're telling me I could have 91 today, right now, you could test me for that. And so there was a lot of mistrust that I had to work through with this patient, and walking that fine line between, at the time, this was the best care that you got. It's just changed. Like, genetic testing has changed rapidly in what we're able to do and how many genes we're able to read through at a certain point in time. So it was a lot of not only just like providing that information in a way that didn't discount his feelings towards this anger, but just trying to provide some understanding. And that mistrust obviously didn't just get solved in that contracting piece, but it was something that I had to work through in all stages of the appointment, which is anger is not an emotion that anger like scares me. So during role plays, like when we had like our peers be angry patients, like that was really hard for me. And so this patient getting angry was something that was really hard for me to work through, but I fell back on that training I had, like that role plays that I had with those angry patients. And that's what really let me be successful in this case. So then, just did my medical intake. I drew that family history to make sure we had all the information about him. Then we went to talking more about that genetic testing and how that would impact management. And that's kind of where that mistrust got brought up again, because we were talking about the different options and what tests would work best for him. And then finally, he decided I just want to be tested for everything. And a lot of this also was managing, his wife came in as well. So it was the both of them in this appointment. So it was like anger and mistrust from the patient, but also just genuine concern from the patient's partner about having kids. Like, they did not want to have a kid that would have a brain tumor at 1 year old. That was really scary for them. And so working through that, at this point, this is the genetic testing that we can do because his family history is the most suspicious. And actually this, when we ran this testing, it came back as negative, which was something that they were not expecting. So it was almost like breaking bad news, but it was good news because it came back negative. But it was just a lot of uncertainty that they had to deal with, which was difficult to navigate. Like in that results call out to them to say, like, we know you have this strong family history. We know you have a personal history, and we didn't find anything, which is really unsatisfying, both for the patient, but also as the genetic counselor in that scenario. And so really, we worked through talking about that disappointment in the genetic testing results, and ultimately got them to a place of just like okay, out of the things that we could find, there was nothing. Like at this point, we just need to like be confident in that we did everything we could at this point and like take that closure moving forward. And so we connected them with like, they had a preconception appointment, but we also emphasized for when they're thinking of doing and like planning for pregnancies and having kids, recommending that prenatal genetic counselor, like the space Andrea was in, not necessarily the fetal care space she was in, but like the prenatal space in general, where you're sitting down with a genetic counselor, walking you through what genetic testing you can do to ensure that you have a healthy baby in front of you. So that was the cancer space. And yeah, that was all that I had about my case. So any questions about either of the things that the cases that Andrea and I talked about, or just questions for us in general? Thank you for going back there. Yeah, there's our emails listed there if you have any questions after this that you don't want to voice now. Yeah.
So when you see these patients or individuals, is it like counseling in the sense that they're gonna come back to you? So you're gonna see them once a week kind of thing, or just you're meeting with them once, twice, kind of orient them to goals and how it's gonna be managed?
It depends. So I know in prenatal, you can keep seeing the same couple that are just having kids every other year or so. So you can meet with the same patient. What I always like to tell patients, especially when they're gonna go through a difficult time, they don't need to walk this alone. I can be there as much as they want me to, but I'm also not gonna force my way into. So if we need to do genetic testing, usually we at least talk to them on the phone about the results. If they want to come back and meet with us again, we can do that. If they feel like they're too overwhelmed and they want someone else to like know about what's going on, they can also come back to a different appointment and come to that person that they want to learn about what's going on as well. I feel like that's for a lot of the specialties.
Yeah. I will say, so like my interests are particularly in cancer and pediatrics, and that's the follow-up is one thing that I really love about pediatrics, because for some of these conditions, genetics needs to be a part of the care, once a year for these patients, because it's necessary for insurance covering certain medications or seeing if there's another step of testing we can do, because a lot of these pediatric cases can kind of be like a question mark. It's a puzzle that you're trying to solve. And so one genetic test does not solve that. So a lot of times genetic tests are all different. They look at different things. So a part of being in that pediatric space is meeting with and following up with those patients who have negative genetic testing and saying, okay, what are we missing? What else are we looking for? So then sometimes when you get a diagnosis, you're followed up in a specialty clinic with genetic counselors who will see those patients every 6 months, because some of those conditions are a little bit more involved. And so that's where you can kind of get that follow-up space where you're doing a lot of that counseling, talking about family dynamics. How do we tell other family members this? How do we tell siblings in explaining this condition? So I feel like I personally, in my training, I've seen it more in the pediatric space, but certainly there are other spaces in genetic counseling where more follow-up is needed. For example, in like adult neuro conditions like Huntington's disease, if you've seen that. So that appointment setup looks a little different because that's really heavy diagnoses to get. And so those results disclosures are typically in person. And then they typically also have a mental health counselor part of that as well, because our training only covers so much counseling. So a lot of those spaces in neuro clinics will involve a counselor who can be a part of that moving forward. So that's kind of where I've seen that follow-up care come into place. But I always tell patients who are part of your care team moving forward. So if they have any questions or any concerns, they're always welcome to reach out. It's just in those spaces I see it more. Yeah.
Can you talk about the settings in which genetic counselors typically work? Does it work in a hospital setting or is it vary?
Yeah, it varies a lot. So for example, I am in a laboratory rotation right now. So if you don't want to talk to patients, if it's like too much, you don't have to. You can just be talking to their providers. So you can be in a lab, which could sometimes even be remote. So you can be working from home. There's some companies that are just telehealth. So again, you can work from home, be talking to patients, but you're not seeing them in person. You can be in hospitals. You can be sometimes in the hospital from UC also has genetic counselors that work at the medical center. So you can be part of a university. You can be involved in research if that's your passion. You can get involved with higher education and be part of research and become a mentor. We know that our program director, she used to see patients, but she started to just keep blowing more of why is this happening and why is this happening. She just kept having that curiosity. So she moved from patient care to now not only directing the program for us, but also just being involved in research and always trying to figure out that why and that answer to like why something like this is going on. So it can really vary.
I think that's why that's such a hard question to answer, because genetic counselors are in a lot of different spaces. And I think Andrea's highlighted like a lot of them, but they're also in like public health spaces too with newborn screening. I think that genetic counselors, just with our training, we can fit into a lot of spaces. So you can wear a lot of different hats while you're in your roles, as well as just fit into a lot of spaces. And so I really appreciate like that flexibility and that ability to grow into, like, if there's a need, we have the capability to help meet that need. So I think it's just wherever you want to apply your training, you typically can, which I think is really, really cool. Great question so far.
Well, if you guys don't have any more questions, thank you for listening to us and sitting through those cases that we talked about. If anything else later comes up, please feel free to reach out to us and we will be more than happy to answer any questions. And if we don't know the answer, we'll just point you to the right direction. So yeah, thank you.
Thank you. Fun.